the development office is here to finish it. Okay, sure. So we'll finish and then. The presentation called The Lost Master from Medicine 1.
Good morning, everyone. I'm presenting this patient on behalf of Medicine 1. She is a Mrs. M, 54-year-old lady in her postmenopausal period from Erode, presented to us with complaints of 6 months of holocranial headache radiating temporarily associated with painful eye movements, with 1 month of projected non-bloodstained vomiting, at least 1 episode per day. No history of loss of appetite, loss of weight, fever, cough, cold. No other localizing symptoms. She is a known diabetic with well-controlled sugar with oral hypoglycemic agents. She was evaluated outside for the same, was explained of a intracranial mass and started with ATT. She came to us for obtaining a second opinion. On examination, her vitals were stable and her CNS examinations was normal except for a mild left eye abductor paresis. Other examination findings were insignificant. So, with this syndrome complex of chronic headache and projectile vomiting and with mild left eye abductor paresis. Can someone think of any localization or differentials of this? Okay, thank you. Initially, we considered some intracranial space occupying lesion with raised ICT, probably with a cavernous sinus involvement or a chronic meningitis picture. Then we evaluated her with further. Her initial counts were normal and her ESR and CRP were found to be elevated. Then we did an MRI brain imaging that showed enlargement of the pituitary with a central non-enhancing lesion. So there is a pituitary mass. The differential considered at this point were either pituitary hyperplasia or hyperphysitis. Pituitary hyperplasia, to be said, there must be homogeneous enhancement and there must be hyperintensity in T2 weighted images. In this patient, these were not found. Rather, there was a hypointensity in T2 with a dural enhancement, suggesting imaging features in favor of infective and inflammatory etiology. So we further evaluated her with CSF analysis that show a mild elevation in the protein along with expert TB PCR turning trace positive. So for further delineation of the infective and inflammatory conditions, we did a systemic involvement workup that were negative. A minimal tumor workup was made that was found to be within normal limits. So looking over her pituitary activity status, there was deranged thyroid hormonal status. Others were normal. So looking after the mechanical compression effects of the mass, Humphrey visual field analysis was done that revealed no defects. So at this point, we ended up with her having a hyperphysitis that may be due to granulomatous or plasmacytic or lymphocytic or xanthochromic, which were further differentiated based on if it is a xanthochromic a prior cyst that ruptured with depositing cholesterol crystals, that will be evident in imaging. That was not in her case. For lymphocytic, the predominant age to be involved is a reproductive age. She is in her postmenopausal age. For plasmacytic, IgG4 was normal, so it was ruled out. So coming to considering her expert TB turning positive, we thought of a granulomatous hyperphysitis in her. So after a brief discussion with the departments of endocrinology, neurosurgery, and radiology, we started her with weight-based ATT. The ATT she initially received from outside elsewhere was not adjusted to her weight. We did that with a steroid cover. With a careful watching of the warning signs such as visual field defects and functioning lesion, if any, in the future. So there are some very few articles and journals considering this intercellular TB. One such demonstrates intercellular TB is a rare presentation, but incidence and prevalence are expected to grow with increasing numbers of MDR TB. Pituitary TB can present with features of a typical adenoma, differentiated only by radiological and histological features. It is worth considering a trial of an ATT before considering surgery. One another article also emphasized the same. A high clinical suspicion, especially in an endemic area, minimizes invasive procedures and surgical resection. Worth trying a ATT trial. So, few points about primary pituitary tuberculosis is an extremely rare disease. Intracranial tuberculomas account for 0.15 to 5% of intraocular SOLs, of which pituitary as the primary site is unusual, uneasily misdiagnosed as pituitary adenoma. The late diagnosis can result in permanent endocrine dysfunction. So from here, the take-home points, while assessing a pituitary mass, consider differential, though rare. Early identification prevents permanent endocrine dysfunction. Consider trial of ATT in endemic areas with imaging showing pituitary hyperintensity, with careful watching out of warning signs. Thank you.
Thank you, Dr. Sivaranjani. Any questions? Yes, Roger. Go ahead, stand. Stand up.
Pituitary mass, if the mass is showing compressive symptom like sharp compressive, then it should be pan-hypopituitarism. But in your case, TSH is low T4.
No, it is not definitely based on the cell localization of the pituitary. The somatotrophs and the thyrotrophs are delineated in some areas. Which area is more affected, that part can cause the derangement. It is not necessary.
How can you explain low TSH?
So why is there a hyperthyroid? There was a hyperthyroidism in this case.
Hypo, ma'am, with T4 also low.
But the T4 was a high, right? 50, 47. Yeah. So there's a, yeah. So what is your interpretation of the thyroid function test?
Thyroidism, what should you find?
Actually, yes, T4 also, FTC is also low in her.
But T4 was high, right? Quite significantly high, not just a little bit elevated. So what's the reason for that? Was he already on some thyroid supplements? That's one possibility.
Yeah, she was on thyroid supplements after
before testing.
Yes.
Okay, so perhaps that's the reason. Then it was a. But TSH is also, yeah. So in hypophysitis, because of the inflammation, is there a situation you can get hyperthyroidism? So you may or may not get. Okay, yes. Amit. Yes, Amit.
You said that the patient has been diagnosed with hypothyroidism previously.
No, from the outside.
That is previously.
Yes, previously.
What was the report then? So that is the only way for you to find out what was the patient presentation. A patient who is on thyroid supplement, which is slightly more than what she actually requires, will cause a low TSH, and the thyroid supplement that she is taking will cause a T4 to be high. So that we don't know if it is a primary hypothyroidism or secondary hypothyroidism. That is point number one. Second, you said that imaging features are suggestive of hypophysitis. In your case reports that you looked about primary pituitary tuberculosis, what does it present as?
That present as tuberculoma or hypophysitis.
All the data that you presented are based on tuberculosis. Everything that is said that it is tuberculosis, then it will avoid surgery because we are going to operate tuberculosis in its tumor. You're not going to operate hypophysitis. What is the most common cause of hypophysitis? What is the most common cause of hypophysitis?
Lymphocytic.
Sorry, your diagnosis should be based on one clinical presentation. Second, the epidemiology, right? You are not going to diagnose anybody who is having fever with Lyme's disease because it is just not epidemiologically prevalent. So you should know what the most common cause of hypophysitis when you're finding a patient. What is it? It's lymphocytic hypophysitis. Okay, that is the most common cause of hypophysitis. How common is TB hypophysitis?
Rare ones.
What is the among all the patients? Is there a large series of patients with hypophysitis? What would be the percentage? It may not even be featuring, right? It is like, It is only case reports. Correct? Actually, I am wondering if there are case reports of tuberculosis presenting as hypophysitis. You presented a paper says there are primary pituitary tuberculosis, but whatever you presented is on tuberculosis. Is there anything that is there at least one case report that is
In books, it was mentioned, sir, TB can present as hypophysitis. In Williams endocrine, I went through, it was there, but I couldn't get a related article or case report.
you said that it will
But in Williams, it was mentioned till now 20 patients with the tuberculosis hypophysitis were reported. I don't know the details of those 20.
so that is that. But your discussion was not very pertinent to your physician's presentation. You said that you can avoid surgery, give a trial of ADP and things like that, but that is not presence tuberculosis. Now, why did you think that this is tuberculosis? What's the basis of diagnosis?
So two things. One is ruling out the other hypophysitis, we came to conclusion of granulomatous. So predominantly age-related thing. In the late pregnancy and the early postpartum, it is usually presented. It is usually seen. One is age-related, and then with expert TB turning.
One go what ultra big is very highly sensitive, but it's not specific. Just because, especially in cases, basically the ultra. So, and what are the cells like the counts and all this?
CSF cells.
Less only.
How much was it?
7.
And sorry, lymphocytes. And total,
58.
it's not classified.
Because
There is some inflammation.
she was already on ATT since 2 months. That makes first CSF analysis had elevated protein, but outside it was then.
The outside reports, it's worth looking at the reports and the values, so it's important for you to get good clinical data that will help you.
Okay.
So don't discount investigations from outside, especially treatment modifications.
Okay.
They give you information that nothing else can provide you.
After the palsy, how did you explain that?
There was a bilateral cavernous sinus,
Bilateral.
but the patient has clinically only left side. Yeah.
But bilateral cavernous
In the imaging, it was there, but clinically only left side.
Thank you.